delicious meal. And we're here to discuss on the expanding quality accreditation, hospitals and lab. This session will entail a comprehensive exploration of the current state of hospital and lab accreditation in India, highlighting the challenges and opportunities for improvement, as well as strategies to promote quality and accreditation amongst all kinds of healthcare facilities. And we have the convener, Dr. Atul Mohan Kochar, CEO, NABH. Welcome, sir. He will also moderate the session for us. We have the esteemed speakers, Dr. Y.P. Bhatia, Chairman and MD, Estron Healthcare. We welcome you. We have Dr. Poonam Narang, Dean, Maulana Azad Medical College. Welcome, madam. We have with us Dr. Vishnu Panigrahi, Group Head Medical Strategy and Operations Group, Fortis Healthcare. We have with us Mr. Pankaj Johari, Director, NABL. Dr. Ravi Gaur, DRG Path Labs and Partner and Director, Uni DRG Specialty Labs, Delhi. And Mr. Stephen Nesbitt, Board of Director, Toshi Green Tech Automation Solutions. Welcome, everyone. We've just had a superb lunch over here, so we can warm ourselves and extend a little longer round of applause for all of them. Thank you, ladies and gentlemen. Please. And I request Atul sir to take over the charge. Thank you.
Thank you so much. Good afternoon, ladies and gentlemen. So for the post-lunch session, I think this is nothing could be better than learning more about scaling up accreditation, right? It's a very stimulating topic. I hope it's not too sporific, but still we would try to do our best, because the panel today, I feel extremely privileged to announce, is a really glittering panel. Amongst us, on the dais, we have more than 250 years of collective experience, and it will be extremely unfortunate if we don't learn from them, take note from their experience, and implement those things in a pursuit of Viksit Bharat. So we all are aware that Viksit Bharat is a clarion call which has been given to us by our Honorable Prime Minister. 2047 is the deadline, but we hope to achieve that much earlier. And Viksit Bharat, or the theme of today's event, is Swasth Bharat, Viksit Bharat. So thank you, Vicky Hill, for inviting all of us here. Thank you. It's indeed a great privilege for me personally, and all of us, I believe, to be here amongst you. And as I was mentioning, that Swasth Bharat, or a healthy India, has to be based on a very strong foundation of healthy India. Healthy India has to be based on a quality India, and healthcare delivery is basis quality accreditation. So over the past 2 decades, accreditation has emerged as an extremely powerful tool which governs quality of the nation. And to learn more about that, I'm going to start with a context setting before I introduce the panelist, throw some data at you about where we were, where we are, and hopefully where we aspire to be in the next few years. So the Indian ecosystem for accreditation is not very old, it's very nascent. The story started in 1997 when Government of India, along with the industry bodies, notably FICCI, CII and ASSOCHAM, came together to create a body, which was government sponsored, no doubt, but along with a whole lot of industry partners in 1997 under a cabinet note, to create a body with single line vision to create an ecosystem for quality. It was decided that the chairman will always be appointed by the Honorable Prime Minister of India, and the body was named as Quality Council of India. That was a formal. We no doubt had a Bureau of Indian Standard, we had an Indian Meteorology Department, but this body, Quality Council of India, was started with a single focus to draft standard or adopt standard where none were there already. So this is the single line vision. creating an ecosystem for quality. It was nested under Ministry of Commerce, DPIIT, Department for Promotion of Industry and Internal Trade, which is the body which is responsible for the entire trade and tariff which happens across international and national bodies. So this QCI, the body, was nurtured by the likes of very illustrious people, notably the first chairperson was Sri Ratan Tata ji, then Venu Srinivasan, R.A. Mashelkar, equally illustrious people like Amitabh Kant ji, Mr. Adil Zainul Bhai, and currently Mr. Jakshay Shah, they head this body. The healthcare concept came in very late. So under QCI, various boards and divisions were formed, notably the NABL came in later, then the NABCB, the certification and accreditation body boards were there, education and training boards were there. But in 2005, a need was felt when JCI entered India. JCI is the Joint Commission International, which is the home body of USA for healthcare, one of the oldest body, 72 years old. When they entered India and Apollo Indraprastha got accredited, a need was felt that why not India should have its own healthcare standards, and thus NABH was born, because QCI was requested to create a board whereby health accreditation standards could be drafted and hospitals and facilities could be assessed against that. So these are the values of NABH specifically, values which we adhere to daily by bringing in more technology, portals. We are under RTI as responsiveness. We aspire and continue to innovate on a daily basis, and there's lots of credibility which are developed, as I'll just show you. These are the core activities very briefly. We work across the pillars of accreditation, certification, empanelment, trainings, low-cost trainings, free resources. Quality awareness is also a mandate, and we feel, and from that one program in 2005, the hospital accreditation program, today we are running 28 programs in the healthcare stream, our latest being digital health standards and HIS and EMR standards for software vendors. So lots of water has flown. Our 6th edition is the flagship edition, which we released on the 17th of September. It is available and in 12 Indian languages also. The guidebook is available, and it has the coveted ISQA accreditation mark, where it has been much applauded and appreciated. This is the numbers as they stand today for quality and accreditation of various healthcare facilities. I'm not counting the labs here. Under NABH, we are, as on the 30th of October, we partner with 22,677 unique facilities across 28 programs. So this is not a small number, but nothing great also, because where we are in a country as big and diverse as ours, I think we have miles to go before we touch every small clinic, small nursing home, small labs, bigger labs. We also have a fledgling international program, which we do more for cooperation and collaboration, as we learned in the morning that collaboration is extremely important. So NABH has today presence in 8 countries with 18 facilities, and we have interest from 12 more countries, as far and wide as Philippines. So it will interest you to know that out of 195, 196 odd countries in the world, only 37 countries have their own unique standard healthcare standards. And India occupies a place of pride there amongst those 37. So these facilities are currently best of the best in the world, those 22,000. This is a state pin code based mapping of accredited facilities. We have no state except Mizoram where we do not have full accreditation facility as of today. But certified facilities, we have pan-India. So certification is a core area where we plan to touch smaller hospitals just starting out on their quality journey. So these smaller hospitals have started at least something, and they are aspirational, our buckets for further improvement in times to come. This is the total landscape of accreditation and certification. So India, being about 36 countries rolled into one, we take pride that we have managed to have at least one facility under any program at all our pin codes. So that is 19,000 plus of those pin codes. We've already crossed that. Speaking about our colleagues from NABL, so NABL has always been around under Department of Science and Technology. It was decided to be nested under QCI in 2016, and they have been the flag bearers of quality as far as trade, testing labs, calibrating labs. So that besides medical labs, there's a whole world out there on which the entire commerce of a country depends. From everything which you use, from the water which you are drinking to this table which is built, there are specifications. This mic which is there. So each of these is governed by standards which are international. And in India, that flag is held high by our colleagues from NABL. So another pride moment. So NABH accredited labs have practically pan-India presence because their trade and tariff depends on that. Medical labs is another matter. Medical labs, they have a sizable number, and during COVID we saw how they stepped up because government authorized only NABL accredited labs to carry out the COVID testing, and they very staunchly stood up to it, and overnight they could accredit 2,500 plus facilities, which is another pride moment for us. But there are other systems also as far as the accreditation is concerned. So the entire QCI driven NABL, NABH systems, they govern the private landscape. Private, the Fortises, the Medantas, all the chain hospitals, the Escorts, etc., the Max, etc. So similar chains group of hospitals, they are incentivized by the government where it's a voluntary system, which is another pet peeve for us. It's not a regulatory mechanism. So quality is always placed slightly above the regulation, and facilities which adopt such practices are incentivized in the form of financial tangible gains by IRDAI, where third party agencies give some incentive, 10%, 15% above the basis healthcare benefit packages. So for public facilities, we have NQAS led by NHSRC, and we also have a Nirman Bhavan CGHS run IPHS, Indian Public Health System Standards. I'm sorry. So these are the programs, but they are largely meant for small, remote challenged hospitals. They are extremely prescriptive standards, manpower driven, infra driven. So they also add value to nearly 40,000 facilities across the length and breadth of our big and wide diverse country. IPHS standards, they are meant for sub-district hospitals, CHCs, PHCs. So frankly, on paper, we have a very solid, robust system in public health also. But as Dr. Paul said, we have miles to go. Quality is a cornerstone of health, and health is a cornerstone of Viksit Bharat. So somehow, somewhere, we have to bring together everything. And to answer that, we have, just a minute, I'll take a pause and introduce the international healthcare accreditation bodies in the country also. So the body which started it all in India, which triggered the birth of NABH, so to say, is Joint Commission. Joint Commission is 72 years old body, grand dame of the world from US, known as Joint Commission in the US. When it goes out, it's Joint Commission International. There are 54 organizations in the country. NABH currently 22,600 plus. There's Australian Council for Healthcare Standardization also, ACHS, which has 2 organizations. KIMS, we have a stall outside today. But what is to be done? And Honorable PM himself, when today out of the 22 aims, 18 aims are applicant with us. I'm sorry. Of these 18, when aims Nagpur received the accreditation, PM tweeted from the official handle. So that's a lot to say about skin in the game by the policymakers. So there's a regulatory oversight now on accreditation also. There's lots of pride in achieving accreditation, and we feel very privileged to be front and center of it. With that, it is my proud privilege to welcome and introduce again our glittering panel, 250 plus years of collective experience. From the left, Mr. Pankaj Johri, he is the director with NABL. Mr. Johri handles all the medical operations besides so many other things at NABL. Welcome, Mr. Pankaj. Dr. Vishnu Panigre, anesthetist of repute. He heads group strategy and medical administration for Fortis Group of Hospitals, a devout cricketer, a traveler, very fond of traveling, but hands-on quality champion. Welcome, sir. Dr. YP Bhatia, Yashpal Bhatia, everyone knows, sir. He is one of the founding signatories to NABH. So 19 years has passed, sir, lots of water, lots of numbers, but are we there? We'll ask you in a while. But he also champions Venkateshwara Hospital, runs foundations, and he takes pride in now taking on a mission mode accreditation of medical colleges under the label of Astron, which he has founded also. Welcome, sir. Dr. Poonam Narang, one of the first batch of assessors for NABH, a principal assessor, committee member, technical committee member, and currently also the Dean of Medical College, the largest prestigious Dean of Delhi Medical College, my alma mater, Maulana Azad Medical College. Welcome, ma'am. Dr. Ravi Gaur, army man, but a doctor also, loves to travel in remote areas, resource challenge fittings, runs a beautiful lab called RG Path Lab, group of labs, and he's very passionate about innovation, and we hope to learn from that, sir. Mr. Stephen Nesbitt, I met today only, but I'm impressed at the first meeting. Don't let his young looks belie his age. He's a marathoner, trying to keep his head above water, is bossed by his wife, as he told me. That's his hobby. No, but really, he's representing a unique company, and there's a stall outside. You can visit that, so that's where the money comes in. No, but really, it's a pleasure to have you, sir. So, warm welcome once again on behalf of Ficky Heel to this panel discussion, sir. What we could do now is have an opening round of our topic for today is expanding quality accreditation. So there will be questions, but what are your take if we are to achieve Viksit Bharat in 2047 or earlier? What is your take in 2 minutes, your opening comments of where we should go, and then please allow me to direct some specific questions and rebounds to all of you. Mr. Pankaj.
Okay, thanks, sir. I am first of all feeling very proud among all of you, and of course among all of you. Few seconds I would take about to introduce NABL slightly little more, because the topic is that expanding quality accreditation, so it becomes very important to tell me that NABL was started in 1982, in fact. So the NCTCF, that time it was there, National Coordination Center for Testing and Calibration Laboratories under Department of Science and Technology. And from there, it started its journey. And then 1991, it becomes a National Accreditation Board, NABL. And the only mandate which was given by Government of India to NABL was to create accredited laboratory infrastructure in the country. The only aim, behind this was that in 90s time there was a lot of talks when the trade organization, trade barriers was there. The product and services were being exported and something. So a lot of question was there on the quality of the products and services being manufactured here. And every time you are exporting something, the other countries were making our products subjected to the testing, in their labs. They were not believing on our labs. So that time Government of India thought that there should be a accredited laboratory infrastructure equivalent to the world standard. So in that way NABL came. And now it is a proud constituent board of the Quality Council of India, became 2016. The accreditation NABL gives to testing lab, calibration lab, proficiency testing, medical lab, reference material providers. For medical laboratory parts, sir, It started in 2003 actually, when the ISO 15189 and 2003 standard has come first time. And before that, the Guide 25 was there, and even before that, 17125 standard was there, through which NABL was giving accreditation. But for medical laboratory accreditation as per ISO 15189, it started in 2003, in fact, with the standard came. And if you see the 20-year journey that started in 2003, now we have around 2,500 accredited left at present. Of course, we have given accreditation to 4,500 laboratories. Few of them closed and they have merged and acquisition. But at present, 2,500 accredited medical labs are there. So by calculation, if you see, every year, around 125, 130 labs added in the NABL kitty of accredited laboratory. Or you can say that every month, there is an addition of that. So quality is expanding. Accreditation is expanding. I am just presenting this thing in the context of our expanding quality accreditation, that there are, of course, quality is expanding. And if you see these 2,500 accredited laboratories, they are literally serving to the, even if I multiply with a very small number, 100 per lab, 25 lakhs patient per day. Every day, so NABL accredited labs are there. But what Sir has asked, and the theme is expanding quality accreditation. So we are working toward that. We are in the collaboration talks with the state government, with the regulators, with the associations, all medical stakeholders. And we are trying that the current status, which is around 1 lakh laboratory in India, so we can reach to that level, 1 lakh accredited lab in near future. Thank you.
Thank you, Dr. Kocher. And before I start, I'd like to say that I was talking to Dr. Ranupuri, who's a mentor. He's a mentor to me also. He was indisposed, so he couldn't come. But I just talked to him. He's been discharged now. He's fine. And you mentioned about cricket, I think so. I was opening batsman in the college, university. And I was opening batsman for NABH. When 2006, I was in Max. When I was Max was one of the first couple of hospitals which got NABH. So I was part of that.
You were fielding the volleys of the assessors, right?
So what I want to say is that it has been a very significant journey as far as NABH is concerned. But as we were discussing in the morning, the talks that went for Viksit Bharat, Swasth Bharat is important. We are sitting in metro city, in the capital city. This is India. If quality has to improve the way we want, NABH has its site, I think so that has to go into Bharat. So what I mean to say is the Indian hinterland has to start having more of this penetration. And a very significant thing that the public should know, the patient should know, why is NABH being done? Because we have experienced it. By NABH, the quality of care has definitely improved. But the public awareness is still, so I think that's something that we need to communicate going forward. We should, the patient, the public, use the patient advocacy groups. So these type of things have to happen. It is not that we just want the NABH stamp to get that 10%, 15% more than the rack rate, get the empanelments. But the why, because to get anything implemented, the buy-in of people is required. So for the buy-in, I think so that message has to go that by having this NABH standards, which actually, if you look at it from the patient's journey, from the time he or she enters the hospital to the time he leaves, all the touch points are taken care. Not only the clinical part, even the safety aspects. See, because the fire safety, we have heard a lot of times now in the last couple of years, a lot of hospitals have had fire incidents. There have been casualties also. So NABH now has very stringent regulations on. So these sort of, I want to say that this public has to know. You have now started looking at the PROMs, so which is actually gives the functional status of the patient, or the patient leaves the hospital. You may have done 100 joints last month, joint replacements, but is the patient able to walk properly after going home? So these things are captured. So I think so NABH has taken the right steps, but I think so more of communication is required now. But it's a good story to share. I think so we are on the right journey.
Right, sir. Dr. Bhatia, sir, your opening thoughts.
Thank you, Dr. Kochar, for this opportunity. And every time I'm sitting in a event like this, it becomes very nostalgic because I go back to the journey when I was probably working more on American Society for Quality Healthcare Division, trying to talk about them, or on advisory board of JCI and things like that. Back home, it was 2000, and let me tell you, all other things put apart, what prompted the accreditation to come up was the zeal to go for medical tourism. In fact, we as industry body from the CII and all that, we got together and started promoting medical tourism, and we started going abroad. 20 of us, people from Apollo, Sangeeta was there, and Harpal was there from Fortes, and Dr. Trehan, and many of us. And what we realized, we went to Dubai, we went to Abu Dhabi, we went to other places. And the first question in the first 5 minutes was, what kind of accreditation you have in your country? And the moment we started avoiding that question, we have some ISO, we have some this, right? And in the next 5 minutes, most of the important functionaries in the meeting, they had already walked off, just leaving us to have a cup of tea with the junior functioning, and that's the end of the journey. 1 year we spent going abroad, and at the end of the day we came back. Why can't we have an accreditation body? Why we can't start with an accreditation system? That's the time a lead was taken, and under the CII, in fact, at that time, we created a task force to bring some accreditation mechanism to the country. We didn't know how to do it. And probably because of lack of many people who were knowing much about accreditation and all that, I was asked to chair that national task force. We worked for 3 years on the standard, 2002, 2003, 2004, we were working on that with Dr. Naresh Trehan as the mentor. We had a set of standards ready, and I can tell you there were about 1,500 pages of standard which we had created. Then we didn't know what to do. We had whole bunch of papers with us, and next we didn't know what to do. So we went to Kapil Sibal, Mr. Kapil Sibal, we went to his office. What do we do? He says, if you want something to happen, you have to go to a body which has got a government mandate to do it. Until unless you do that, this will remain a piece of paper, it will never happen. And that's the first time I met Girdhar Gyani ji. I went to his office, I told him, this is what we have, and this is what we are doing, and we don't know what to do further. So he said, you have come at a stage when actually the QCI is also looking at the same subject. And I remember the date, this very hall, where we are sitting right now, on 15th of July, 2005, we handed over all the papers, that work we had done to Quality Council of India to take it forward. We didn't know it will be NABH. At that time, we didn't know the name, that name is going to be NABH. And the whole formal process started. A technical committee was constituted with Pawan Kapoor as the chairperson. And we started working on that. And I tell you, at that time, to make the country sensitive about, we are starting with something like this, and knowing their reaction, we didn't know how to do it. We conducted more than 70 workshops across the country. In fact, myself, Gyani ji, and we were practically out on every weekend to a different city of the country to give a talk of these standards, sensitize people, get their feedback. Till in 2006, the standards got adopted, and we moved forward. And congratulations to Dr. Kochar and the predecessors who really took it forward and creating new edition. Now that the 6th edition is already there. My take is something like what Dr. Vishnu Panigrahi brought out, that what is the driver for these standards to be adopted? Is the driver the commercial reasons? Is the driver a compulsions which are more or less, if not regulatory, semi-regulatory? The vision with which the standards came up as a quality tool, and adoption it as a quality tool with quality as the driver, where the organization says, I'm doing it because it's giving me quality. Rest of things are the offshoots which are going to come to me. I think that's what we have to look for that. One of the aspects which Dr. Kochhar and the subsequent committees, which I always feel that we could look into, on one hand, we have to upskill the standards. There's no way out. Every new standard, new edition comes out, it has to be upskilled. On the other hand, we have to understand, again what Vishnu said, the quality and NABH is not the mandate of the vertical towers of excellence. Right now, with the type of standard which we are establishing, which we are creating, it needs a lot of skill set for an organization to go in for these standards. The vertical towers find it easy to do it because they have a huge team working on it. They may have 12 people, 15 people working on the quality and make it happen in their organization. What about a standalone hospital in Northeast? What about a hospital in remote part of the country, tier 2, tier 3 cities, where availability of a quality person may be difficult? So from that point of view, how we can ease out their life, how we can make them understand that your quality can be driven by it, and driven by it within the resources which can happen in your own. I think what I'm saying is a very complex thing. But I think ultimately, if we want what we are saying, a Viksit Bharat, Swasth Bharat, and not only a Swasth Viksit Bharat, a Swasth Viksit Bharat delivering quality healthcare to everyone. Absolutely. We talk of all the A's, but accessibility, availability, affordability, everything we are talking about. But I think if we are talking of an accredited healthcare for all, then we have to create a mechanism where there's a matrix where we are able to upskill the standard as required, at the same time make it easy for people to happen with their own resources. Thank you so much.
Dr. Poonam, madam. Coming from a perspective of a dean of a medical college, are we doing enough for the medical students when they pass out? Are they aware of what is quality, what is the accreditation? Should we be doing more? Opening thoughts, and probably you could build on that.
So first of all, thank you for having me be a part of this stellar panel with such tall names. Dr. Bhatia talked about nostalgia, and he triggered my memory of, association with names like Girdhar Gyani, Arun Maurya, Dr. Narottam Puri, Dr. Bhatia himself, and so on and so forth. So I was an assessor before I became the dean. I've been associated with NABH since 2008. Early 2008, I got initiated into this journey of quality, bitten by the quality bug, and then I'm been a carrier ever since. I infect anybody who comes in contact with me. That's been my story on the accreditation front or the quality front. 2 years back, I was assigned this responsibility of being the dean of Maulana Azad Medical College. In addition, I'm also a principal of BSA. I talk to students, and I see there is no common talk between my two lives, my journey as a quality person and my journey in medical education. There is nothing in common. With all its constraints and all the infrastructural, human resource deficiencies, I've realized one thing, that Indian medical graduate is way more superior to any other foreign medical graduate, be it any country whatsoever, and I'm so proud of it. I can give you 200 deficiencies in our medical education system, but still what we produce in terms of an Indian medical graduate, in terms of knowledge, the skill, the capability, the problem solving, and the commitment, I think we would be at one of the top, medical education producers. Here I want to bring in one famous quote. There's a book also regarding this. He was asking me about the books that I've been recently reading. All I needed to know in life, I learned at kindergarten. If we have to take this journey of quality anywhere, upscale accreditation, introduce quality to, you know, each and every person, we have to start at what is the kindergarten of medical education, that is the medical colleges of our country. We have to initiate our medical students into the basic concepts of quality. Don't need to teach them 6th edition of NABH standards, but inculcate them into them the sense of, you know, keeping track of their outcomes, auditing what they're functioning, introduce concepts of safety and basic levels of quality. We just teach them to do the best from their sides. We don't teach them to look at it how what they think is the best is being translated into patient care or not, whether it is useful to the person that they're doing it for. We take pride in doing our best. We don't take pride yet into doing the best for the person who needs it. If we start with that sense, probably we will contribute to accreditation systems or quality in a big way. They'll be our torchbearers. They'll take our journey forward for us wherever they go, be it our country or the entire world that they're serving healthcare to. I'm sure they're going to take these words with them wherever they go. When the alumnus comes and meets me, which is an annual event in Maulana Azad, that people who have studied at Maulana Azad and gone and are working at different places in the world, they come back to touch base with us. Whenever I meet them, I'd ask them about whether you know, they think they were able to, they felt confident enough and capable enough to be serving in those countries. And I pointedly ask about these areas which concern measurement of the work that they do, the quality and the auditing. They say that, ma'am, there is a big, big gap. If they can adapt to this kind of functioning in other countries, why can't we initiate these concepts right in our medical education? If there are any policymakers, I would request them to take note of this fact, that introduce these concepts after every chapter, just a small para about how to measure the outcome, or how to, for example, in pharmacology, when you're teaching them prescription writing, give them those 5 points so that they audit their own prescriptions. At least they're aware. They'll fudge the data, I'm sure, in their logbooks. It's all right, but they'll at least be introduced to the concept that they need to put in those 10 things in their prescriptions, and they should be aware of those checkpoints. Just, this would be just an example of how we can introduce a concept, basic concepts of quality in our medical education system. Thank you.
Well, I think I would, ma'am, just like to add that not only best doctors, India produces the best of nursing officers, healthcare administrators also, and with all the empathy which is rooted into our culture, I would say everyone connected to healthcare directly, indirectly, is better produced here. And there's so many of us also. Over to you, sir.
Well, good afternoon, everyone, and thank you, Dr. Kocher, to being here. It's my privilege and to sit next to Dr. Bhatia. In fact, we all look up to him whenever you talk about quality. I think I always say he's synonymous with quality, sir. Thank you, sir, for being here with us. You know, like today we were talking about the first inaugural session. Dr. V.K. Paul talked about foundation. You know, like, I believe, you know, what is the foundation of healthcare? The foundation of healthcare, I believe, is a trust. That's the basic trust. Now, how do you develop the trust? Like, okay, in a smaller town, I come from a very small town, Gwalior, nearby. We had one family doctor, right from the day you were born till about 25 years, go morning, evening, every time, he knows everything. You trust him, whatever he does. But in a place like this, where there are like so many hospitals, you keep traveling all across, how do you develop the trust? I think the trust is basically nothing but quality, it's a journey. Because it's a journey you probably, and quality actually is a journey to trust. I mean, that's a fundamental. If you want to have to work on, that's where I think we have to work on. That's a very important part. And besides that, I think if you don't have a roadmap to attain the quality, how you develop the trust, and I think ultimately you won't be able to deliver the proper healthcare as we're looking for. You know, I'll just share something which is something way back. I come from Indian Army background, And probably I was one of the first medical officers to go up in Siachen Glacier, which was almost like 8 months we stayed. And nobody really stays there for more than 3 months now. And we have to walk all the way. And there are places in between. It's far away from Ladakh. It's about 2 days by road drive, 3 days for road drive. There's some place in between. There is a place called Thois. Now of course now it's a tourist spot. At that point in time, talking about 1985, 86. It's a small district. There's no. I mean, one of my commanding officer had sugar problem, and I said, let me get my blood test done, sugar test done, and we walked around 5 kilometers. That's a small village. Not even a single facility existed there. Again, probably we went further to another, drove down another 6 hours and found somebody, a grocery shop guy is having a 1 glucometer, an old strip. And we don't know what kind of quality it is. I think that's something we came back now to town. When you go to the remote areas, when you come to the city, I think there's too much of gap. Too much of disparity exists. I think how do we do that? That point of time there was no resources. But today we have technology. We have point of care devices. We can integrate them. We have resources. Everybody is now globally connected to each other. I think that's one thing we need to look into it. When you talk about quality, go back, connect to the actual user, the last man out of the post out there. They require the same services and quality services what we get in Delhi, Mumbai, Hyderabad. Let's go beyond that. I think that's something, if we can do that, that'll be justice to the quality. That's one thing. Second, also important thing, like I'm basically an oncopathologist by profession. And I had worked in multiple labs across, and the first time, when we're talking 2005 and 6, one of the best accreditation probably, of course, is the College of American Pathology Accreditation, CAP accreditation in pathology. We had a first audit in CAP, and probably they felt that all the assessors used to come from abroad. All the team was coming from there. And this was a costly affair, because not only the requires participation, but also they travel, stay, everything with us. I said, why can't we have Indian people doing this accreditation? We can have one inspector from there. We can have at least 2 from India. It took me 4 years that we negotiated, we talked, and they said, approve us. And the American inspectors believe that, no, Indian inspectors are not worthwhile, you won't be able to do that. I said, it's not possible. We fought. In fact, they said, okay, we let audit 2 CAP labs, and you prove us that CAP lab without any confirmation, and with no NCs, non-confirmatory. And we did that. So ultimately, after 4 years of struggle, fight, putting across, in 2011, I think we were able to convince the CAP authority, there's a quality exists in Indian people too. They are good assessors here. And we were the 5 assessors, internationally certified inspectors, India-based inspectors to audit. And I was one of the first one to do that, along with we have a couple of people. And that's the credit probably goes to. Today, of course, we have almost 40 odd such inspectors in India who are actually walk along with the CAP team and do the audit. What I'm trying to say is that I think it's a drive. You need to work on it. And I think all of us probably, I'm talking about the skill. I think we have wonderful strength, we have standards, we have determination. We've seen right from the QCI and what you're doing, Coach. I think we can do wonders. And we have to change the mindset. We need to change our culture. It has to come into a culture. It can't be a checklist like certification. It has to be a culture. And there is always reluctance, will always be there. But I'd like to end with a quote. They said, change is the, you can say, very hard at first, very change. It's messy in between, but you're just at the end. Ultimately, if you work hard, you achieve quality, you've done your bit toward the healthcare. That's what.
Thank you. I think that's a great idea, sir. Being self-reliant with an example of CAP, I think what anyone could do, we could do better. That's no doubt, but we learn from them and implement them. And the other thing which made so much sense is when Pepsi and Maggie and Uncle Chips can reach the remotest part of, you go to the remotest, go to Ladakh, Leh, first thing you see is Pepsi ad. If they can reach there, why can't quality or our NABH logo be implemented? Not only logo.
Say exactly the same, you say that. Because I was one that posted in one place. Anybody happens to go to, I think, Mizoram, the last village is called Chimtupui.
Right.
And there's a huge stone at the border, big stone, which can be civil rock. And in that, there's a Coke ad later in there. But there's no soap available in the town.
So that's the 16x we are looking for. If we should not be satisfied with 2x, 3x, 4x. Viksit Bharat can only be achieved if we achieve 16x at a steady pace. But for the audience, you may ask your question. Please write them on your those letterhead, those pads, and hand it out to Mr. Ozair out there, who will collect. Just raise your hand, and we could ask. Mr. Stephen, sir, would you like to run your presentation or your opening thoughts? Sure, please.
Which is the key to advance.
I will do it. Please.
Thank you, Dr. Kochar. Thank you very much for the kind introduction, and I want to also thank you very much for disclosing my age to this good audience, and that was fun. And I want to make an apology to this esteemed panel that I'm not a doctor, and there are so many doctors on this panel, but my father was a doctor, so I'm hoping you will benevolently accept me on your panel because of my DNA. Anyway, I am an investor in and sit on the board of directors of a U.S. company by the name of Green Tech Environmental. And we have, through the United States-India Strategic Partnership Forum, begun to manufacture our product here in India and taking it out of China. And secondly, was introduced to a very fine company by the name of Toshi Automation Solutions here in the greater Delhi area. And the founder and CEO, Mr. Kapil Sachdev, is right here in the front row. Kapil, can you raise your hand? And so we formed a partnership with them. And we're honored to participate in this program and think that our focus of Swachh Bharat is right on target, and specifically for this panel, quality of patient safety, because we want to talk about an area called healthcare acquired infections. And this is a problem globally, and we have some solutions for that, and want to talk just about the issue with you today. So, we're not. I've messed it up. I apologize. And which is the forward key?
I think this one.
Okay, terrific. Thank you. So please excuse that I'll start with some data from the United States, but then I'll tie it into data from India, that in the United States, there are 2 million people every year that get healthcare acquired infections, and sadly, 100,000 of them die every year. And the founder of our company likes to position that 100,000 by focusing, using an example that if the most commonly used commercial airplane, a Boeing 737, which has about 250 people on it, if sadly it would crash today, for the next 3 weeks, every single day on the television and all the media would be talking about that crash. Well, the healthcare acquired infections just in the United States are like a 737 jet crashing every single day for the next 365 days. And about 4% of patients that come to American hospitals come down with a healthcare acquired infection. If you look at what the World Health Organization says in India, that number is between 7 and 12%. And that means that, according to WHO, in excess of 1.5 million people needlessly die every year from HAIs. WHO further goes on to say that 70% of HAIs are indeed preventable. So the question is, how do we prevent HAIs? And we believe there's a number of touch points that we could look at that can help. And number one is to have a process that's a continuous process instead of a scheduled process. As you likely know, many times today, these cleansings and disinfectants of rooms in hospitals is done on a scheduled basis. And as an example, you may seal off an operating room and can't use it, and you'll wheel in what's called a robot with a UV light or a hydrogen peroxide mister, and you can't use the room for a while, and it does a very nice job of disinfecting the room. But as soon as the person walks into the room now to take that robot out, new problems are introduced into the room, contaminants, and they begin to multiply. We believe that something to be considered would be to have a continuous process of disinfection and not necessarily just a scheduled process. Another piece is to have it what's called no touch. It doesn't need people to intervene to be able to continuously disinfect a room. So the next touch point would be, there are a number of different types of solutions for HAIs. Number one is a passive solution, and another is an active solution. And I'll use an example again from our founder on this, that he says if you have a mouse problem in your house, you can use a passive solution, and you could buy a mouse trap and you put it someplace and you bait it, and you hope that the mouse comes by and gets trapped by the trap. You bring the problem to the solution. Or you can have an active solution whereby you buy a cat, and that cat then will roam around the entire house and find the mice and get rid of the mice. Similarly, with HAI disinfectant approaches, you can have a passive solution like a filter, where you try to bring the pathogens to the filter and try to trap them, or you can have a solution that molecularly changes the air and has it go through the rooms following the air circulation process in those rooms in order to track down and then to kill the pathogens. So let me go to the next chart here. There are a number of different technologies that you can use. As I said, you want to molecularly change the air, the particles in the air. You can use the humidity in the air along with the oxygen to create these activated oxygen particles, then that shoot out into the room and continuously clean the air and clean the surfaces in the room. That's the same type of technology, by the way, that's used on the space station. So it's one that's been proven and safe for a long period of time. So the next thing you want to do is you want to make sure that you have testing that is done, next touch point, and to make sure that that testing shows that it's safe for not only human beings, but for animals. And in many cases, some of the hospitals that you can talk to here have shown not only is it safe, but there's a 42% reduction in employee absenteeism, so it's keeping your employees healthy as well. But you want to do the then third-party laboratory testing, and you get a multi-log reduction in some of these pathogens that are common that cause healthcare-acquired infections. Whoops, I'm going the wrong way, sorry. So that's what we wanted to raise as an issue, and we are absolutely excited to be here on this panel to discuss this, and are willing to accept any questions that you might have. Thank you.
I think that was extremely relevant. You know, what Mr. Stephen highlighted was that there are elements of unintended harm everywhere in this room, but more so in any healthcare facility. So hospitals, unlike what we believe are not safe places, even for attendants, or especially for attendants or the patient. And these standards which we draft and assess against, or other institutes draft and assess against, are exactly geared to take care of unintended harm. So unintended harm is the top 10 reasons for mortality and morbidity worldwide. And if we can prevent anything, whether by use of these filters or by processes, by policies, or by infrastructure, I think we would do better. And by the way, for every question, there's the possibility of winning a car, you know, by Ficky Hill. I hope so. Organizers are listening, right? Or Mr. Stephen himself could sponsor one, right? No. So, but let's have, before we come to the questions, this is Dr. Partha Roy. right? QA, QC protocol for, you are a doctor, sir, right? Yeah, so that writing fits that. No, I'm joking. So, QA, QC protocols for clinical labs and biotech labs are on gene therapy are different and difficult to find common grounds. Okay, let's make it generic, sir. Most of the standards, probably, which probably NABH also. So let's come to what are we not doing right? We have patted ourselves enough on the back that we produce best doctors, we produce best standards, we touch so many people. But what's then stopping us to grow and grow to the remote parts? Because India is not this all. India is, as everyone agrees, much beyond the boundaries of metros, right? And majority of people are below poverty line. So if we are to achieve a Viksit Bharat, which is a developed nation at least, and we are as strong as the weakest link in the chain. And we also agree that we cannot achieve Viksit Bharat by creating islands of excellence, you know. We have to reach out to the last in the line and give solutions. And probably somewhere simplification of our protocols, as Dr. Partho has pointed out, also figures in. So one part, let's hear it from you, sir, this time. What are we not doing right? Mr. Stephen, would you like to comment? Should we doing something different? Your perspective on Indian healthcare. I mean, what should we do to change what we should be doing, you know?
I'm not sure I'm the expert on
As
Indian
a
healthcare.
visitor, as a visitor's perspective, one
Yeah.
line.
Interestingly, at least as it relates to HAIs,
Yes.
which is our particular focus, there are standards in some areas, but there's standards on how you do it, not necessarily standards on what the results are. As an example, there are a lot of different ways that you can use equipment that create certain molecules, like ozone or hydrogen peroxide or some of these types of things. And there are standards in most parts of the world that said it cannot be above a certain amount of parts per million out there. So those are pretty strictly enforced and watched. But as far as what the results are, which leads right into patient safety, which is the focus of your session here, I'm not aware that there's a whole lot of standards.
Absolutely. Okay. Dr. Godson, what are we not doing right? One thing which we should be doing as a NABL, NABH, or as a nation, what we should be doing?
I think what we are not doing right is, collaborating properly. I think collaborating.
Collaborating.
Because
Okay.
I think this is standalone, they have island of excellence. Standalone labs are there. Excellent mindsets are there, standalone here and there. But without it, when talking about Swasth Bharat, we need to, government and private bodies have to come together. Unless there's a mandate right there, some kind of a collaboration has to have happened. Because this is otherwise, you can imagine, like, there's no regulation even to regulate, register a lab as of now today. How do we talk about, we have quality standards. Standards have come out, the very good standards are there. But unless those are implemented on the ground, and how can do that? Either by order, mandatory, or it could be an equal participation. So I probably feel like, one suggestion probably we can go is, of course, we can talk about automation, AI, technology, much more, but simplest thing, even probably at a district level hospital, a government hospital, or a medical college, let them run a small EQUAS program. I'm talking from the lab point of view. If they can be accredited by some bodies, and they run a EQUAS program, adopting 50, 100 labs, and run a small controls. Let the culture, a mindset of quality start. I think that's something will take us a long way. Because then means, okay, there's an additional responsibility to an institution or to a district hospital, but that has to be mandated by the government. Probably that collaboration will take us to the next level, because we will start from the basics. Now that's something which I will suggest here.
No, excellent. I think there's lots of sense in, because some regulation has to be there. Currently, it's so difficult to open a eatery. You can't open a restaurant outside. There are 54 to 200 compliances required. But anyone, could set up a table and a chair and start prescribing drugs. Obviously there's one degree, but no one validates. So that's another thing. Ma'am, what are we not doing right?
So I'll just take my previous thought forward. We're not introducing this bug right now at the beginning of the story when we're building
Catch them
doctors.
young, right? Catch them young.
Catch them young and introduce the concepts of quality right at the beginning. That is one. But I don't agree. We don't have presence of quality in smaller towns or this thing. There is a large network of initiatives that has been taken by NHSRC, and Quaz is doing a wonderful, wonderful job. And I see very good facilities in remote places of our country where we never could think that PHCs could exist like that. Now the government has taken it in a big way and they're doing a very wonderful job. And their method is to incentivize the adoption of quality. Because in government sector, you don't threaten them with, loss of job or loss of revenue or anything. You have to get work done by incentivizing them. And that is the way that NQA's system works. And their standards are very, very basic, very, very doable, very relevant to what is required at that level. And probably they are overwhelmed if they read this, fifth edition or sixth edition of standards. They will not touch it. The smaller facilities, the government level facilities where we are struggling to deliver basic health care, if that is their level, we have to bring standards to that level so that they happily adopt it, and then that could be a step. Then you could gradually upscale that and take it forward from there. So I think NABH should adopt something like that. It is there in a smaller way, but not as popular as NQAS, because NQAS is incentivizing them to do that. Entry-level standards of NABH were doing probably the same thing, but again, the incentive and the motivation was lacking from that. Maybe there could be a partnership between NABH and NQAS or IPHS standards, and they could create a common platform where the terminology, the language, everything is harmonized, levels of standards are very, very similar, so that everybody is on the same board when they start. You can give them smaller steps to scale initially and then upscale them eventually.
I think that's a fantastic idea to have one nation, one
yeah.
standard, so that it's a complete harmony. And more importantly, I would like to add that not only healthcare professionals, but why not common citizen be taught in the school about how to demand quality, how to recognize quality, not only in healthcare, but every field. So that demand should come from the people, and only then the industry would back up or nation would wake up or something. Sir, what are we not doing right, sir?
I'm reminded of, there was a beautiful article when India completed 60 years of independence, and Times of India carried an editorial that India has got some of the best written legislations in the world, but most poorly implemented. Similarly, I think we have some of the best brains which have worked on the standards in the world. We have brought it out with great effort, great thing. But my young colleague sitting in the corner of the country, is he able to understand that standard? Is he able to interpret that standard? And pardon my saying, many of our assessors, I say with a lot of apologies, that many of our assessors, are they able to understand and interpret those standards correctly? At the end of the day, the hospital which is going for it is left to the mercy of interpretation bias of the assessor for doing it right or not doing it right. And at the end of the day, the intent of the hospital is never respected. So what it actually means, at hospital may be intending to implement the quality, wanting to put the quality into place. And I'm reminded very well of about 15 years back, I was working with Gujarat government, 18 years back, I would say, 17, 18 years back. To improve the quality, we were given the responsibility to improve the quality of healthcare in 36 district hospitals of Gujarat by then Chief Minister Modi ji. And in our briefing, mid-term briefing, we said, डॉक्टर साहब NABH मिलेगा नहीं मिलेगा उसको छोड़ दीजिए, वो बाद की बात है, पहले सभी हॉस्पिटल के अंदर क्वालिटी का कल्चर एस्टेब्लिश करिए, क्वालिटी का कल्चर एस्टेब्लिश हो जाएगा, NABH तो आ ही जाएगा. And our mandate was completely changed, not to hunt for NABH, not to look for it. In fact, I remember my first talk I gave in the government of Gujarat. There were 300 participants, and I thought I gave a beautiful talk. I talked about standards, I talked about everything, and I went across to that. And at the end of the day, during the lunch, when I was talking to a few people, he said, "कैसा लगा?" सब बहुत अच्छा था, बहुत अच्छा बोले, मगर गुजराती में होता तो बहुत अच्छा होता. अब समझ ही नहीं आया. Congratulations to NABH that now they have brought the standards in 12 languages, they have interpreted. But what my main point here coming is, the intent of the organization need to be respected. The interpretation has to be simplified and uniformed so that an administrator, a young administrator or a clinical administrator, a doctor who is running a hospital, when they try to interpret, they are able to interpret, and their interpretation should be similar as the interpretation of the assessors.
Correct.
Because assessors are the face of NABH. At the end of it, explaining to each individual assessor, because I have been associated with the accreditation process for more than 500 hospitals so far. And I do understand the pain of the hospitals, which probably is never understood. I understand that pain, that they have all the intent, they have all the energy, they have everything they want to do it. At the end of the day, I am talking of like we were doing a civil hospital in Rajkot, and the team had done a beautiful job. I must say that they had transformed in heritage building into a beautiful healthcare complex, including at that time computerization of all OPD records and everything. And ultimately, when the assessment team says, एक foot का there's a ramp of 1 feet, and there's a gap of 6 inches in that from which a child can fall, and that's why this hospital is not fit for this thing. So ultimately the team lost the interest. They said, forget about NABH, we don't need it. As a government hospital, it's not our requirement. So what I am trying to say is that the intent of the organization, the uniformity of the interpretation of the standards, the uniformity of the interpretation standards at the assessor's level, and ultimately make it so simple and comprehensive that all levels of administrators, the top administrators to the youngsters who are actually implementing to the clinical
Points very valid, sir. Points taken. In fact, QCI and NABH and NABL are working towards putting a video guidance for each of the 651 objective element in public domain. What exactly is expected out of a written text, and what hospital should do, what assessor should perceive, what our common colleagues, our colleague citizen should see, because they also have an equal right to see what at least a hospital or healthcare facility should offer. So we are bringing out in public domain. The project is Mitra and E-Mitra, and whole lot of standardized templates we'll be putting out starting 14th of November. I mean, that's about to be launched. So another initiative. But thank you so much. I think this is great wisdom. Dr. Vishnu, sir.
Yeah. I'll start with, actually, Dr. Narag rightly mentioned, I think so. This journey has to start at a college level, number one, because that is where the first sensitization happens. Second, I think so, in the healthcare ecosystem, the quality manager or the person who's driving the NABH thing, how they interact with the clinicians, with the nursing staff, with the technicians, because all the parameters that have been put, as Dr. Bhatia rightly mentioned, it's very nicely done. A lot of thought has been put it. But what is the benefit that the patients get? That should, so anything going, we have infections in the hospital, every hospital has it. But if you do a root cause and find out these are the causes of that, that's sharing it with the doctors and taking their inputs. So they should see they should see the benefits of following the NABH guidelines. Because then what will happen? They'll become your ambassadors to see that the NABH standards are properly adhered to followed, if they are done appropriately, the patient, who's the most important person in a hospital, gets the benefit. The other part, I think so, across, whether it's public sector, private sector, I think so the transparency has to come in. We were talking about trust deficit and all that. So anyone walking into the hospital, their outcomes should be now tracked and put on the public domain.
Yes.
I think the time has come now, because if you recollect, I think so the only place I think so where it is done on a regular basis, year on year, I think the state of New York, about 20 years back, it comes out in the paper, newspaper, on a yearly basis. Dr. Vishnu Panigar, if he is the cardiologist, he's working in, say, Mount Sinai, these are his outcomes. So the public takes a conscious decision of going to that hospital, going to that clinician. So that transparency has to come in. So what I'm saying is that once this comes in, automatically you will see that people adhere to the right norms, follow it. Because no doctor, no nurse likes to do any harm to the patient.
Absolutely.
Very clear. But sometimes with, the NEBH has become, for the clinicians I'm talking about, that it is another tick box, karo, accreditation aa jayega, board ho jayega, tali marenge, thoda sa. So that, the why is not being explained to them. And public, I'm coming to the public, most important is the patient advocacy, that has to come in now. I think so, we are not taking the public into confidence that if you have NEBH, it uplifts the standards of patient care.
Absolutely. I think patients have to equally participate in their care. They should be as aware of the facility, as aware of the standardization, and somewhere it is our duty to explain to them. I think points are extremely valid. Mr. Pankaj,
Absolutely right, sir.
what from inside you feel you are not doing right?
No, I was saying that.
Can be improved.
Yeah, actually, I feel that what we were not doing for long, now we have been doing. We are seeking the support and cooperation and collaboration of all the parties, all the stakeholders now in creating a quality culture among all. Fortunately or unfortunately, health is a very sensitive subject for all. Yeah. And we as Indians, we are large in quantity, high in quantity you can say, and highly price sensitive, and wishing for the highest quality when we are talking. But when it comes to the health, when someone of our own family or own relative or anybody is in the hospital in the need of our, that time we want the service. We are not seeking that time the quality services because that quality culture is not there. That time we are forgetting each and everything. We are only satisfied our patient is getting attended, our laboratory results are okay, we are getting result in 10 minutes, half an hour, 1 hour, 2 minutes, that time we are not asking about any TAT, any quality, uncertainty, traceability, how good it is, how the laboratory results are making impact on this. So what I mean to say is that as a laboratory part, if I say, lab is a very small segment of, very small segment of a hospital sector. Hospital is the front, laboratory is on the back side. So laboratory people are not seen outside. What their work is mostly unrecognized, most of the time. But we forget that the treatment, the clinician opinions and everything is depending on the diagnostic a lot. Standalone laboratory also. Another important thing in the healthcare sector particularly is, unlike in testing, industrial part, where a shipment is rejected completely on the basis of a wrong report, in the healthcare sector, if a clinician is finding that report is not clinically correlated or not okay, he would prescribe to go for another laboratory, go for another round of the testing or something. So that accountability is not there. Who has produced that result? And the clinician is not asking that laboratory, that connectivity is not there because there is no such regulations or no such mechanism is there where clinicians or patient should ask the laboratory that my clinician is not believing on this result, what has gone wrong? Nobody is asking. So what I mean to say, we need to build a quality culture among everyone, until unless even at the emergency time we are not seeking the quality services and simply getting satisfied, okay, I got it, it will not work.
Absolutely. I think there's so much sense in that. I mean, we are no doubt a price sensitive market. We buy a car, we ask kitna deti hai. And the intent, what everyone pointed out, when we go for accreditation also, people try to, bargain and see what's the value. Some get into accreditation for putting a certificate and getting the incentive. The intent of imbibing a culture is extremely important. And very pithily, Mr. Pankaj, you pointed out, somewhere amongst healthcare, prevention, screening, all those things are also extremely important. I mean, it's too tempting not to take a second helping of the jalebi which was served outside, during lunch, or a cake also, because it's there. So how to regulate and take care of our own health is also somewhere which is beyond your accreditation, which is somewhere something for everyone. But to scale up, I think it's each one of our duty. So do we have time? Who's keeping time? Just 10 minutes. No, 10 minutes is a lot of time. So 10 minutes, we will take questions. I have 2 questions, but they are proprietary. One is about, they've specifically tailored it for you. HAI is, again, a doctor is writing. Hospital-acquired infection is the major, okay, sir.
Can you reframe it? Because
yeah, please.
by the time I made the question, Dr. Stephen mentioned that. Now, HAIs is a very major problem issue. Even WHO said 7.4% of the people come back with this thing. And one of the solutions suggested by Nesbitt was air purifier, right? That's it. But the issue is taking these things to Bharat at an affordable way. So these are requiring power and volume and all. But there are also some technologies like visible light disinfection, which can be put on during the presence of people, which is non-UV. So, and they don't almost use any power. So, but how strict is NABH levels for the measuring the ambient this thing, because it removes the things from levels, and how can this be made approachable to everybody?
So, yes, please.
Affordable solution for this.
Affordable solutions for HAI as an example. So we need to reinvent, find affordable solutions
Yeah, they are available.
available.
See, to answer your question on the NABH, during the assessments, they look at the areas, patient areas. Suppose the OT, for example, the air changes, how many times it's being changed every hour. They check the HEPA filter. So all these things are checked. So what I'm saying is that, as Dr. Bhatt rightly mentioned, the processes have been very well made. So we have to getting the implementation and see that it is adhered to. So I think so we are on the right track,
Okay,
but he put a lot of emphasis on that, the implementation. And as I said that
To measure the biological contamination, there is no visible quick measurement, right? We need to culture them for two.
So
two
let
days.
me explain that, sir. Whenever we draft standard, it's a very elaborate process. I'll just quickly inform what goes behind our certificate. The decision is not taken by the CEO certainly, or the assessor, or the standard, or the secretariat. It is taken by an independent committee. How these standards are drafted? Standards are drafted on a premise that on a given day, 80% of the ecosystem should be compliant. It should be compliant of common practices. So much of proprietary innovation is flowing in. Every day there are changes which are for betterment. We have to draw, and there are guidance from our colleagues abroad. There are best practices in US, Europe is another level, Dutch countries are absolutely another level for antibiotic intake, for healthcare management, human resource management. So our standards take care not only of the patient, but of the staff, for the facility, for everyone. It's an ecosystem. And it's a real challenge for experts. So many of them are here also. They sit through, stifle that data, shuffle through that data, put something together, put it in public domain, get the comments, reincorporate, then keep revising it. There's so many dynamic KPIs. It's a very elaborate process which takes, as soon as we release the 6th edition, the work for 7th edition starts. But innovation is always factored in based on validation and affordability and applicability. If in a certain pocket something is happening, so be it. But is it okay for a standard, for a country our size and shape? So that common, but best practices of another level, they do find their way in. But I've been told that we are rushing for time, so I'll take very quick one-line closing comments of your vision of a Viksit Bharat and healthcare and accreditation.
Well, I believe that obviously patient safety is critically important, so I'm glad that there's a focus on this, not only in India, but globally. And there's certainly the hospital business is a business,
Yes.
but we can't lose sight of the fact of patient safety.
Absolutely. Thank you so much. Dr. Gaurav.
My vision is very simple. I think every healthcare facility or a provider should adopt some basic globally acceptable standard of quality. That's the fundamental.
So some
Beyond that,
basic standard should be there, whether it's a lab or a hospital
Somewhat.
or a nursing home or a OPD or a IPD. Some should be there. Thank you.
I've said that before, grassroots level induction of concepts of quality. My bachas, when they go out to serve anywhere in the world, they should not be surprised that there's another system of auditing which we were never taught in India. So that would be my vision and my
Thank you.
take home.
I think I would be repeating what I have said, that the quality should transition from the vertical towers of excellence to the horizontal spread across the country, where what we are calling as the Bharat, or the other Bharat as we call it, which is away from the metro towns, they also get the quality health care, but they are so much authorized.
Thank you. Sir.
Yeah, same thing. I think so. While we are expanding our healthcare immensely, the volume is not important, the quality is important. So to Dr. Bhatia's point, which I also mentioned earlier, is that Bharat is where the action has to be there. So the tier 2, tier 3 cities, the smaller. So we have to support them. My request to NEBH is, I'm also part of NEBH thing, but my request is that those smaller players, some handholding is required.
Yes.
Because sometimes they are the consultants go there and tell them a lot of things, a laundry list is put up, they get overawed. So that's the reason. So we should handhold them. That's something that we can discuss separately, because unless that is done, the smaller players will.
So we are releasing that consultant program called Mitra and E-Mitra, which will change the dynamics as you mentioned.
Because that's important. The second thing I'm saying is that at the hospital level, this the doctors, nurses, the buy-in from them also is important. And the third most important part, which I want to like to say, is that in the NEBH assessment, the HR part is there. But the people who look after the quality part, some basic norms should be put in place, so the hospitals adhere to it, because it is always looked at, because I'm from the corporate health sector, these things are looked as a cost center. It is not a revenue generator, but good quality always brings in good revenue. That is, there's no doubt about it. But so these, some handouts should be there so that they adhere to this.
Thank you.
If you ask my vision of the Viksit Bharat is, from the QCI point of view, that I would like to see in 2047 that every hospital, everywhere is NABH accredited, every lab is NABL accredited, and most importantly, how it would happen, that fear of, instead of having a fear of facing assessment, there is so much confidence in the mind of every Indian, particularly in every healthcare professional, that he is willingly to demonstrate the technical competence. Willing to. So that is my vision, that where in 2047 every Indian is so much competent and that he is willing to demonstrate his competence, so that confidence is generated everywhere.
No, thank you so much. Thank you so very much. I think this has been an incredible panel, and let's have a huge round of applause for our panelists. And one more round of applause for Shilpa. Shilpa, please come. She has been coordinating this panel wonderfully, and the entire FICCI HEAL team led by you. Round of applause. Thank you so much. And you've been a wonderful audience. Some of the questions could not be taken, but I think the message is conveyed. So for Viksit Bharat, I think all of us are responsible. And Swasth Bharat is our duty as well as it's of the accreditation. And no doubt with all your inputs, we would work hard towards scaling up the accreditation and quality in healthcare. Thank you.
Thank you, sir, for moderating the session so well. And ladies and gentlemen, here we take a short break of 10 minutes, and we shall assemble over here back in this hall for digitization of healthcare and democratization of AI. Where are we heading? A big question. For the next session, we come over here in Silver Oak, and the other session in Gulmohar Hall will be enhancing operating effectiveness, driving high quality and cost effective last mile care to tier 1 cities and beyond. Thank you.